on today talk. So today talk, we're going to talk a little bit about aortic regurgitation. So basically in layman term, aortic regurgitation mean aortic valve that is leaky. So we have aortic stenosis, which is a narrowed or blocked aortic valve, and we have aortic regurgitation, which is a leaky aortic valve. So whenever we are assessing aortic regurgitation, and seems as our approach in assessing all valvular disorders, we need to answer few questions. We need to ask ourselves what we're seeing, whether it is an acute, for example, infective endocarditis, or is this a chronic regurgitation? Number two, we have to ask ourselves what is the severity of the regurgitation, because remember, normally only severe valvular disorder warrant intervention. What is the etiology of the aortic regurgitation? For example, if it is because of aortic dissection, then that might warrant urgent trip to operating theatre. And number four is the patient symptomatic. Because once the valvular problem is severe, in the patient is symptomatic, then that is a ticket for them to go to operating theatre. Number five is the LV function good. Okay, so for example, if you have someone with moderate aortic regurgitation and they have symptoms, we try to find other cause of the symptoms because the aortic regurgitation is only moderate. If let's say they have severe aortic regurgitation and their LV function is good and they are asymptomatic, we can wait first. If they have severe aortic regurgitation and they are symptomatic, then we have to send patient to surgery. Another reason we send the patient to surgery, if they are having severe aortic regurgitation, even though they're asymptomatic, but their LV function has decompensated. So this few scenario why we need to send patient for surgery. And usually these five questions is applied to all valve problems that you come across. I give you some salient tips first. It is important to recognize acute versus severe aortic regurgitation as a separate entity. So most of the characters or parameters in the guideline about when to intervene in aortic regurgitation is actually for chronic aortic regurgitation. Because in acute regurgitation, the left ventricular had not time to compensate and dilate. So the rule where you go for surgery once the EF is less than 50% and the systolic dimension is more than 5 centimeter might not apply for those with acute severe aortic regurgitation. Sometimes in patients with acute aortic regurgitation, the left ventricular end diastolic pressure can be so high to the extent that when you look in 2D echocardiogram color view, that the appearance might not be so remarkable. So beware about this kind of issues. And you could also see more common the phenomenon such as early diastolic mitral valve closure and early diastolic aortic valve opening in patients with acute severe aortic regurgitation. I will show you what I mean later. And most common cause of acute aortic regurgitation is either because of aortic dissection or infective endocarditis. Usually in this situation, regardless of whether the LV have decompensated or not, you need to go for surgery. So in patient with aortic regurgitation, which of the view is used to determine jet area relative to the left ventricular outflow tract? So one of the characteristics to determine the severity of aortic regurgitation is we look at the jet area and we compare the jet area to the annulus area. So we look at the jet diameter compared to the annulus diameter. So if let's say the jet diameter is less than 25% of the LVOT diameter, then we say that that is mild aortic regurgitation. If let's say the jet diameter is more than 65%, the LVOT diameter, we say that that is a severe aortic regurgitation. And which of the view that we use to do that? Is it A, apical 5-chamber view? Is it B, apical 3-chamber view? Is it C, parasternal long axis view? So is it apical 5-chamber, apical 3-chamber, or parasternal long axis view? Or is it parasternal short axis aortic view? So the answer in this situation is parasternal long axis view. So that's the best place for you to use to determine jet area relative to the left ventricular outflow tract. The reason being, if you do this in apical 5 or apical 3 chamber view, you might overestimate the severity of aortic regurgitation. What about this question? All of the following shows severe aortic regurgitation except, okay, so vena contracta of 5 mm, holodiastolic flow reversal in abdominal aorta, pressure half time of 100 millisecond, effective regurgitant orifice area of 0.35 centimeter squared, or regurgitant volume of 65 mils, which doesn't show severe AR. All right. So in this situation, the answer is A, vena contracta of 5 millimeter. Vena contracta for severe aortic regurgitation is 6 millimeter, okay, as compared to mitral and tricuspid regurgitation, which is 7 millimeter. So aortic regurgitation is 6 millimeter, and mitral and tricuspid regurgitation is 7 millimeter. Holodiastolic flow reversal in abdominal aorta is quite a specific sign of severe aortic regurgitation. So the further distal along the aorta, you see the holodiastolic flow reversal, the more specific the sign is. What about pressure half time? So pressure half time, the shorter the pressure half time for aortic regurgitation, the more severe the aortic regurgitation. So if it's less than 190 millisecond, that is called severe aortic regurgitation. However, there is a caveat. This pressure half time, it is not very good in patient with chronic aortic regurgitation. So it is not sensitive to rule out severe aortic regurgitation in patient with chronic aortic regurgitation. So even though it is specific, it is not sensitive. We more often see a very short pressure half time in acute aortic regurgitation. What about effective regurgitant office area? So this is the same as mitral regurgitation. It is 0. It is not the same. It is lower than mitral regurgitation. So the answer is 0.3 centimeter squared. And for regurgitant volume, it is actually the same with mitral valve. That is 60 mils or 60 mils, 60 milliliters. So why is the difference? So why in aortic regurgitation, the EROA for severe is 0.3, but in mitral regurgitation, it is 0.4. Now, the reason is aortic regurgitation occurs during diastole. And during diastole, the period of diastole is longer than systole. So for mitral regurgitation, the EROA of 0.4 centimeters squared equal more or less to regurgitant volume of 60 mils, but for aortic regurgitation, it is lower. EROA of 0.3 centimeters squared. That is more or less the same as regurgitant volume of 60 mils. So once again, I repeat, the value for severe aortic regurgitation for vena contracta is 6 millimeter. Holodiastolic flow reversal is specific for severe aortic regurgitation, but it is not sensitive, especially for chronic AR. Pressure half time that is less than 190 millisecond is considered severe aortic regurgitation. EROA of 0.3 centimeters squared and regurgitant volume of 60 mils is considered severe aortic regurgitation. So the image that I show you at the bottom right corner of your screen is a pulse Doppler of a descending aorta just distal to the level of aortic arch. So this is the flow in the descending aorta, and you can see there is reversal here. Okay, this is the diastolic flow reversal. Now, if you look at here to here, you can see that this is not a holodiastolic flow reversal. But if you look from here to here, so there's a bit of more flow here. So this is what I mean by holodiastolic flow reversal. When do we intervene? If let's say someone come to you and you look at the echocardiogram and the echocardiogram shows severe aortic regurgitation, is it when the EF is less than 50%? Is it when end systolic dimension is more than 5 centimeter? Is it when the patient is symptomatic? Or is it all of the above? Okay. Now the answer to this question is all of the above. So if you see someone with severe AR, so that's why it's important to determine whether they're having severe AR in the first place. So if you see someone with severe AR, and if they develop symptoms, regardless of their LV function, they need to be sent for surgery. Another time is, if let's say someone comes with severe AR, they are not symptomatic, but their ejection fraction is less than 50% and or, so not necessarily both, systolic dimension more than 5 centimeters, then you intervene in severe aortic regurgitation. There is very important yet subtle difference between severe aortic regurgitation and severe mitral regurgitation. Remember, in severe mitral regurgitation, we tend to be aggressive. So we, in a center of excellence, we even intervene in chronic severe mitral regurgitation before the patient develops symptoms, and even when the LV function is good. Okay, so we do not want to wait for severe mitral regurgitation. For chronic severe aortic regurgitation, on the other hand, the patient can have severe AR for quite a long time before they develop symptoms or before their LV decompensate. Therefore, we can wait and we should wait. Why? Because a lot of severe AR happen in young patients. Okay, for example, you have 25 or 30 patients with severe AR and bicuspid aortic valve. Now, you do not want to subject them to operation too early. Because if you give them bioprosthetic valve, you know for sure in 10 to 15 years time, they need to have reoperation. If you give them metallic valve, you have complication from bleeding and a lot of other complication. So you want to wait as long as you can before the patient, you do operation. So you wait either until the patient becomes symptomatic or the LV decompensate. We do not want to be too rushed in chronic severe aortic regurgitation. Now, in valvular heart disease, as in heart failure, we have started to stage in American Heart Association and American College of Cardiology, the staging in valvular heart disease. So we have stage A, stage B, stage C, and stage D. So how do we understand this staging? So the stage A is someone that is at risk of valvular heart disease. For example, if let's say you live in Borneo, so that's an area that's endemic of rheumatic heart fever, so maybe they can call you stage A heart failure. Or you are old patient with a lot of atherosclerosis, so that is also a risk factor for aortic stenosis, so that is stage A. Now stage B is progressive valvular heart disease. What that mean? That mean that even looking at echocardiogram, you already have structural evidence of either aortic stenosis or whatever valvular heart disease, okay? But it is not yet severe, so that is stage B. What about stage C? Stage C is severe, okay? Stage C is severe but asymptomatic. Now, stage C is divided into two, so C1 and C2. In stage C1, you are severe, you are asymptomatic, and your LV is good. In stage C2, you are severe and you are asymptomatic, but your LV has decompensated. And lastly is stage D. Stage D is severe and symptomatic. So usually stage D, we straight away send for operation. So I show you here again. Stage A is at risk. So anything that is less than severe valvular disease and they are having at risk is stage B, is progressive disease. Stage C is asymptomatic severe, divided into C1, LV is compensated, and stage C2, LV is decompensated. And lastly is stage D, someone that has severe and symptomatic valvular heart disease. So let's look at our first case for today. So we have 32 years old man presented with exertional dyspnea. So when you examine him, his lung is clear, the JVP is not elevated. However, you hear an early diastolic murmur. So how can you explain the shortness of breath in this patient? Okay, so ECG are all normal, but when you do an echocardiogram, you see this. Okay, so you look at the figure on the right side, so you can see that the patient have aortic regurgitation. So one way to see the severity of this aortic regurgitation is look at the distance of this color and compare the distance to the distance of LVOT. So this one is definitely more than 65%, the distance of LVOT. So that is a sign of severe aortic regurgitation. That is one. Number two, you can also look at vena contracta. So what is vena contracta? Vena contracta is the region where the narrowest portion of the jet, you see whether it is more than 6 millimeter. So if it's more than 6 millimeter in aortic regurgitation, it is severe. And also you can look at holodiastolic flow reversal, and also whether there is decompensated in terms of left ventricle. So what you do is, you also look whether the LV size is more than 5 centimeter in systole and is the ejection fraction less than 50%. So this patient has severe aortic regurgitation, and we want to know. So we already answered the question. It is severe aortic regurgitation. In terms of symptoms, the patient tell you that the patient is symptomatic. So this is a symptomatic severe aortic regurgitation. If there is no other cause of aortic regurgitation, this patient should go for surgery. And we have to ask ourselves as well, why does this patient such a young age develop severe aortic regurgitation? And of course, our answer is provided by this echocardiogram. You can see that this patient have 4 leaflet of the aortic valve. So 1, 2, 3, and 4. So this patient has quadricuspid aortic valve. So patient with quadricuspid aortic valve most commonly present with severe aortic regurgitation at a young age. So this is quite severe aortic regurgitation with quadricuspid aortic valve. So this is in the situation that you have to be very careful. You do not want to intervene prematurely. So even though they are severe, if they are asymptomatic and the LV is okay, to go for follow-up first. But in this patient, he is already symptomatic, so this patient need to go for surgery. Now, bicuspid aortic regurgitation, quadricuspid aortic valve most commonly present with aortic regurgitation. Bicuspid aortic regurgitation, more commonly aortic regurgitation, but also possible to present with aortic stenosis. Okay, bicuspid aortic valve. Also the same for unicuspid aortic valve. Unicuspid aortic valve can also present both with aortic stenosis and aortic regurgitation. So AR can progress very slowly. It is very important to make accurate quantitation as we do not want to prematurely replacing the valve. Whenever there is a combination of severe and symptomatic, the patient will most of the time can get a ticket to go to the operating theatre. Remember a rule that I call rule of 50-50. What is rule of 50-50? If the patient has severe AR and they are asymptomatic, look at their left ventricle. If their ejection fraction is less than 50% and their LV systolic dimension more than 50 millimeter or 5 centimeter, so meaning that this patient, their LV has already decompensated, then this patient need to go for surgery. Remember that patient with severe aortic regurgitation, they have high preload and also high afterload. This is because there is more volume of blood that need to be pumped with a small, with the same orifice aortic valve. So someone with similar orifice aortic valve, but with aortic regurgitation has more afterload compared to those without aortic regurgitation. Therefore, in patient with chronic aortic regurgitation, if you operate, even if the EF is less than 50%, the EF can recover back to more than 50%. So this is also opposed to mitral regurgitation, where you have preload reserve and afterload mismatch. In chronic mitral regurgitation, you do not want to operate late because once you operate when the EF is less than 60%, in chronic mitral regurgitation, the EF might not recover. So I tell you one more time because this is an important and subtle difference of severe AR and severe MR. So in severe AR, it's okay to wait until the LV decompensate to less than 50% first, because after operation, due to the fact that afterload is increased, the EF might improve. For chronic mitral regurgitation, in the other hand, you have to be aggressive because once the EF get to less than 60%, it might be irreversible then. So the vena contracta that is more than 6 millimeter and holodiastolic reversal in descending aorta or abdominal aorta is signs of severe aortic regurgitation. And also I told you AROA of 0.3 centimeter squared and regurgitated volume of 60s. And why 0.3? Because AR is in diastole with a longer period compared to MR, which is in systole. In chronic severe AR, almost all of the time, if you look at LV diastolic, not systolic, LV diastolic volume, it will already be dilated. So it is very rare for someone with have severe AR to have non-dilated LV in diastole. So what is the possible aortic regurgitation etiology? So it can be because of degenerative trileaflet or bicuspid aortic valve. It can be because of quadricuspid aortic valve. It can be because of unicuspid aortic valve. And one of the most important etiology that I do not want you to forget is ventricular septal defect. If you remember, both your outlet ventricular septal defect and perimembranous ventricular septal defect, the defect is actually just adjacent to the right coronary cusp of the aortic valve. And during diastole, this right coronary cusp can actually prolapse into the defect and cause aortic regurgitation. So the VSD might be small, But to prevent damage to the aortic valve, we might need to close the VSD. Other reason is also aortic dilatation, secondary to most commonly hypertension, connective tissue disorder, or aortic dissection. So remember that aortic root, i.e. from the annulus to the sinotubular junction, the leaflet actually expand from the root to the sinotubular junction. Okay, that's why even if you have dilatation of the ascending aorta alone, because ascending aorta include the sinotubular junction, you can have aortic regurgitation. And of course, infective endocarditis can cause chronic, so it can cause acute severe aortic regurgitation. And lastly, in Malaysia, especially your rheumatic heart disease, and also remember radiation heart disease can also cause aortic regurgitation. So this is just the parameters, as I've told you before, how to determine whether this patient have severe AR. So the length of AR more than 65% compared to the length of LVOT. The very steep pressure half time, I use less than 190 millisecond. And at the bottom, the regurgitant volume of 60%, the regurgitant fraction of 50%, and EROA of 0.3 centimeters squared. So they have tried to classify aortic regurgitation as they classified mitral regurgitation. So if you remember, in mitral regurgitation, we have what we call a Carpentier classification. So in aortic regurgitation, also we have classification. This is called El-Khoury classification. Also, depending on the leaflet motion, so we have type 1. So in type 1, we have a normal leaflet motion, but the problem is dilatation. Type 1 is divided into type 1A, 1B, and 1C, and also 1D. In type 1A, the one that is dilated is all the sinotubular junction and above. So that can cause aortic regurgitation. Why? Because remember that hinge point of the aortic valve leaflet at the top is actually the sinotubular junction. That is 1A. 1B is the effacement of both sinotubular junction and sinus of valsalva. 1C is the effacement of the annulus itself. Type 1D, there is no aortic dilatation, but you have perforation of the leaflet, for example, in patient with infective endocarditis. So that is type 1. So if you have a normal leaflet motion, but you have dilatation of the root, so different part of the root. Type 2 is excessive movement of the leaflet, such as cusp prolapse. So not just in MR, also in AR, you can have cusp prolapse. And type 3 is cusp restriction. For example, someone with degenerative calcified aortic valve. So that is El-Khoury classification that mimic the Carpentier classification of the mitral regurgitation. This is the guideline on aortic regurgitation. So for me, the way to think of valvular disease is simple. Think about whether it is severe or not. And when it's severe, see whether it's symptomatic and whether the LV has decompensated or not. So if we look at the list here, for example, if you have severe aortic regurgitation, so you have fulfilled the echo criteria. If you're symptomatic, which is stage D, that is class 1 indication for go for LVR. What if you are asymptomatic severe, stage C? Now, if you have stage C2, for example, your EF is less than 50%, then you can go for operation. That is also class 1 indication. If your end systolic dimension is more than 5 centimeter, that is class C2, but the indication is 2A. Still weaker, but still for aortic valve replacement. Usually those with moderate and mild aortic regurgitation, we don't intervene unless they are going for bypass. So let's look at another case. We have a 60-year-old male with shortness of breath who was referred to you from district hospital for shortness of breath. So upon examination, the patient have both systolic and diastolic murmur. Now ECG shows non-specific intraventricular conduction delay, so the QRS is white, but it's not typical left bundle branch block or right bundle branch block or ventricular tachycardia. What would you do next? Of course, you do your normal electrocardiogram and you do echocardiogram. So that's the echocardiogram, okay? Now, you look at the echo here, it is striking that the ejection fraction is actually very poor. You know, the ejection fraction is only in the region of 25% or so. So this is a 2D without color. But if you look at the anterior mitral valve leaflet, it doesn't open normally during diastole. You know, during diastole, the anterior mitral valve leaflet will open all the way there. So we have to ask ourselves a question. Why is LV function down? Why the mitral valve does not open completely? Even though when you look at the leaflet of the aortic valve, the leaflet looks normal. There is no thickening or signs of rheumatic valvular heart disease. Now, the aortic leaflet is not thickened, so you can't really even see the leaflet. So this is not aortic stenosis. So we have to explain too. Why is the reason? the anterior leaflet has not opened completely. Now, when you look at the parasternal long axis view with color, finally you have gotten your answer. You can see the patient has severe aortic regurgitation, and this aortic regurgitation jet is actually eccentric. And it's eccentric to the extent that it actually impinges on anterior mitral valve leaflet during diastole. So as it impinges the anterior mitral valve leaflet during diastole, the mitral valve leaflet cannot open fully during diastole because of that jet. So that is one answer that we have, one question that we have answered. So the other question, why the EF is poor? Of course, also because of aortic regurgitation. Okay. Now we look at the echo. From the jet, we can tell that this is at least moderate. Okay, but looking at the EF, and maybe we want to look at the descending aorta to see at holodiastolic flow reversal, so we can determine whether this is severe aortic regurgitation or not. Okay, but however, there is one phenomenon here that definitely tell you that the LVDP is very high, that show you that the patient have severe aortic regurgitation. So what is the phenomenon? So look at the apical four-chamber view here. Okay, I just wanted you to take a look at the mitral regurgitation. Look at the mitral regurgitation. If you notice the mitral regurgitation at my pointer here, okay, look at mitral regurgitation. There is two types of mitral regurgitation. During systole, you have one mitral regurgitation, so that is systole, one mitral regurgitation. However, during diastole, you have another mitral regurgitation. I just show you now. Mitral regurgitation, that is another. So that is mitral regurgitation, that's another one. So that is systolic mitral regurgitation, then you have the other one. So you have systolic mitral regurgitation, and you have the other one. All right. So what is this phenomenon? So this is what we call diastolic mitral regurgitation. So what is diastolic mitral regurgitation? You know that mitral regurgitation happen in systole. So why in such situation it happened in diastole? It happened because the LVEDP is so high, such that you have mitral regurgitation even at end diastole. So that is a very specific marker of severe AR. If you look at the flow here, you can see that this is T wave, this is end systole. You can see that even during diastole, you have a flow there. So this is diastolic mitral regurgitation. Okay, that is diastolic mitral regurgitation, which is a specific sign of severe aortic regurgitation. How to quantitate the severity of aortic regurgitation? So I already talked about it before, the 6 millimeter distance. We also can use a PISA method. So this PISA method is not only valid for mitral regurgitation, we also can use for aortic regurgitation. I've already talked about EROA and regurgitant volume before. Another way that I occasionally use is the continuity equation. Okay, so what is continuity equation? So there is one continuity equation that you use, for example, in aortic stenosis. For example, that is flow into the LVOT is the same as the flow outside the aortic valve. However, in aortic regurgitation, we cannot use that same valve to do continuity equation. So we have to use continuity equation based on two valves. So whatever that is coming out from aortic regurgitation, compare it to things that coming out from the other valve. So the most common thing that I do is I look at the flow out of the pulmonary valve, and then I look at flow out of aortic regurgitation, aortic valve. So the stroke volume across the regurgitant valve minus the stroke volume across the computant valve is the regurgitant volume of that valve. Okay, one more time. Stroke volume across a regurgitant valve minus a stroke volume across a competent valve is the regurgitant volume of that valve. So if, for example, if our stroke volume across the aortic valve is 160 mils and our stroke volume across the pulmonary valve is 100 mils, okay, so the difference between the two, so 160 minus 160 mils, that is the regurgitant volume of that aortic regurgitation. Okay, that's another way that I usually do it in echocardiogram. So we have few ways, okay, we can do the qualitative or semi-quantitative. We also can do fully qualitative. One we can do using PISA. Another time is we can use using continuity equation from two different valves. Okay, so the stroke volume in the regurgitation valve minus stroke volume in the competent valve. Okay, so I wanted to show you a few pictures here. So this is a picture of how you do vena contracta in parasternal long axis view and see whether this is more than 6 millimeter or not. And if you can look here at this picture on the side there, so this is apical 5-chamber view. If you notice that the AR is going upwards here, if you zoom, you can also see, look and adjust your Nyquist limit to get a hemisphere here, a PISA hemisphere. Okay, so what you do is you can use the PISA equation. So 2 pi r squared times the arising velocity. So arising velocity is whatever velocity that you have changed. So for example, here is 40. So 2 pi r squared. So r is the radius of the radius of the PISA. So 2 pi r squared times 40 is equal to effective regurgitant orifice area times the AR Vmax. And then you rearrange the equation, then you can get your EROA. So for example, your EROA is equal to 2 pi r squared times the arising velocity over the patient AR Vmax, and then you can get your effective regurgitant orifice area. Okay, if you are not clear about this, we can talk about it later. It's exactly the same as you do with mitral regurgitation. So I hope you understand that. I will explain it if you don't understand later. Now, this is another question. So this is someone that have echo with endocarditis and shock. So what is the best treatment for the patient? Is it aortic valve replacement? It is mitral valve replacement? Is it intra-aortic balloon pump, or you cannot tell? Okay, so I just wanted to show you, they already show that this is actually mitral valve. So there's AML, so it's anterior mitral valve leaflet, and we can't really see properly the posterior mitral valve leaflet. So if this is anterior mitral valve leaflet, this must be the left ventricular outflow tract. Now, if you look at the left ventricular outflow tract, you can see a line here, okay, a line that is go up and down. There's line there, okay, and you look at the LVOT diameter, maybe it's slightly dilated. What is this? So this is actually severe aortic regurgitation. Now, how do I know that this patient has severe aortic regurgitation? So look at this. So this line here is end diastole. Okay. Now, you know that the mitral valve leaflet should open throughout diastole. It should open throughout diastole. Okay. It only closed during systole. But if you look at the mitral valve, it opened, but before the diastolic end, it already closed. So the mitral valve opened. Before the end of diastole, it already closed. So this is premature closure of the mitral valve at end diastole because the LVEDP is so high. So this also explains why we can have diastolic mitral regurgitation. So I explain again. So this is mitral valve. Mitral valve should open throughout diastole. However, because the LVEDP is so high, the mitral valve closed before the diastole ends. So this is premature closure of the mitral valve in diastole. And this also explains diastolic mitral regurgitation. So the reason is the LVEDP is so high. How do I know that the patient have aortic regurgitation? So this shaggy line here in the LVOT is actually a vegetation that go in and out of the left ventricular outflow tract. So this is severe acute aortic regurgitation secondary to infective endocarditis. Obviously, the treatment should be aortic valve replacement. It is not MVR because we are not dealing with mitral valve. It is not IABP. Never put IABP in patient with regurgitation. It will make the regurgitation worse. Okay. So this is the hemodynamic to explain the closure of mitral valve. So you can see the yellow line here is the pressure inside the left ventricle. In patient with severe aortic regurgitation, the LVEDP go up very rapidly and it go up higher than normal. So as you can see, the LV diastolic pressure go up higher than the left atrial pressure even before the end of diastole. Now QRS is end of diastole. You can see that the LVEDP go up above the left atrial pressure even before the end and diastole. So this is called premature mitral valve closure and possible diastolic mitral regurgitation. That is the first one. Another one, if it's really severe, as you can see, as we go through the diastole, even before systole end, the LV diastolic pressure is already higher than aortic pressure. So your aortic valve can also open prematurely. So mitral valve can close prematurely. The aortic valve can also open prematurely before diastole end. Okay, so that is two phenomena that we can see in acute severe aortic regurgitation: premature mitral valve closure and premature aortic valve opening. Okay, that's the two. So this example of someone with premature aortic valve opening. So you can see this patient have this is the aortic valve opening and closing, opening and closing. So let's say I do the line. So that is the line of diastole. Okay, that is diastole. You know that aortic valve should start open in systole. It should start open in systole, but you can see it open very early in diastole. Okay, this is premature aortic valve opening. So you have premature mitral valve closure and premature aortic valve opening. This is another echocardiogram of a patient. Okay, now look at this. In a descending aorta, you can see very severe holodiastolic flow reversal. And you know this is severe aortic regurgitation. Now look at the parasternal long axis view here. That is the descending aorta. You can see that the LV is very dilated. Again, the same thing. Look at the anterior mitral valve leaflet. Look how the anterior mitral valve leaflet is struggling to open. It is not mitral stenosis because the anterior mitral valve leaflet does not show any indication of mitral stenosis. So what is the problem here? What is your diagnosis? So obviously, we can see the diastolic flow reversal. So this suggests severe aortic regurgitation. And we wanted to see also the color flow. Okay. So the mitral valve leaflet is, someone can call it this reverse doming of the anterior mitral valve leaflet or reverse hockey stick appearance. We can also see fluttering of the anterior mitral valve leaflet because the jet is impinging on the anterior mitral valve leaflet. Okay. Now look at the echo now. Okay. Now you can see a very severe eccentric mitral valve regurgitation impinging on the anterior mitral valve leaflet. Okay. However, we also see another flow. You can see a flow that is going to the right ventricle there. You can see in my pointer, there is flow going to the right ventricle. Where does the flow come? Does the flow come from the left ventricle or the flow come from the aorta? Now, if you look properly, the flow happened during both systole and diastole. In ventricular septal defect, it predominantly go in systole. But in this situation, it is in systole and it also in diastole. So you have aortic regurgitation. You also have this suspicious flow that go into the right ventricle in both systole and diastole. So what is that? So remember, continuous flow, if you heard on the heart, you will hear continuous murmur. And the reason you have continuous murmur is few things. One is patent ductus arteriosus. So any connection from great arteries cause continuous murmur. So PDA is from descending aorta to the pulmonary artery. Another reason is if you have Blalock Toshik shunt from right subclavian artery to the pulmonary artery. Okay, the other one, of course, if you have coronary artery fistula, also you can have continuous murmur. And lastly is sinus of valsalva rupture. So this is an example of sinus of valsalva rupture. Because you have a continuous murmur, you have a flow actually from the right coronary sinus into the right ventricle. Okay, so this patient not only have aortic regurgitation, patient also have sinus of valsalva rupture. So this is a dual pathology. The rupture is into the right ventricle. So the rupture can be either into right ventricle, right atrium, even pulmonary artery, okay? But less commonly, the left ventricle. So patient with sinus of valsalva very commonly have concomitant ventricular septal defect. Why is that? Because VSD is one of risk factor for us to develop sinus of valsalva aneurysm or rupture. Because when we have VSD, we can have prolapse where we pull the cast into the defect and that might cause aneurysm and rupture. So always try to find a concomitant VSD, but sometimes it can be very difficult because the valsalva rupture is just above the defect that you can't really see the defect. Look at the short axis view here, all right? So this on top here is the right coronary cast. At the bottom is none and left coronary cast, okay? And you can see here from short axis view, this is the defect, that is the sinus of valsalva rupture there. And if you look here, if I were to pause at the correct time, so this is the windsock appearance of sinus of valsalva rupture. So you have a right coronary cast that is ruptured into the right ventricular outflow tract, and you have that continuous flow there. So I play again. Right, you can see the windsock appearance of sinus of valsalva rupture from the right coronary cast into the right ventricular outflow tract. So this is someone with ruptures of sinus of valsalva and also severe aortic regurgitation. So this is usually a congenital problem because of localized connective tissue disorder. And concomitant ventricular septal defect might also contribute to sinus valsalva aneurysm and rupture. So one more question. So aortic regurgitation is associated with A, supracrystal VSD or outlet VSD, that's the same. B, perimembranous VSD. C, muscular VSD. Or D, inlet VSD. So what is your answer? So the answer is very easy. The answer is either supracrystal VSD or perimembranous VSD. How do we remember this? We remember because both of these defects is adjacent to the right coronary cusp. So there is a risk of that right coronary cusp to prolapse into the ventricular septal defect, causing aortic regurgitation. Okay, so look at next case here. So look at the aortic valve. Okay, what do you think about the aortic valve? So whenever you see at the short axis of aortic valve, see and determine whether it is calcified, and try to determine how many leaflet. Remember, determination of number of leaflet, it is not made during diastole. For example, when you see the Mercedes shunt, Mercedes-Benz sign. Remember, in diastole, you might confuse the refi as one of the leaflet. Okay, so you look at systole and you look how does the shape of the leaflet during systole. Now, if the shape is hemi-elliptical like this when it open, so that means that you have a patient with bicuspid aortic valve. If the opening is triangular, that is a trileaflet aortic valve. So this is an example of bicuspid aortic valve. So this patient have bicuspid aortic valve. This is a pulse wave Doppler of the abdominal aorta. So what is the comment of this pulse wave Doppler? So in pulse wave Doppler, usually you will see a forward flow and the forward flow will stop. You don't usually see this continuous flow during diastole as well. So this is called a diastolic runoff in the aortic vessel. When you have diastolic runoff, what does that mean? So that means that the patient have coarctation of the aorta somewhere along the vessel. So this is a test. So whenever you pulse your abdominal aorta and you see that it is abnormal, always be suspicion of coarctation of aorta. Okay, so this patient with bicuspid aortic valve and a coarctation of aorta, which is a known association of bicuspid aortic valve. So we have talked a little bit about aortic regurgitation. Okay, so I have talked about how to assess in terms of echo severity of aortic regurgitation. We have talked about when to send the patient for surgery, remembering symptoms and also the 50-50 rule, the EF of 50% and also the systolic dimension of 5 centimeter. I've tell you the importance of differentiating acute severe aortic regurgitation with chronic severe aortic regurgitation. I have also explained to you the hemodynamic behind premature closure of the mitral valve and diastolic mitral regurgitation and premature opening of the aortic valve in severe aortic regurgitation. The subtle difference between severe aortic regurgitation and severe mitral regurgitation. In one, we have to be very careful to send for operation. In another, we have to be very aggressive. And I've shown you multiple examples of different etiology of aortic regurgitation. So my take-home message is pay careful attention to appearance from 2D echocardiography. Remember the appearance of anterior mitral valve leaflet that I have shown you over and over. Remember the holodiastolic flow reversal as a specific sign of severe aortic regurgitation, especially more distal of the aorta. Remember the quantitation method. At least remember how we do the continuity equation, i.e. stroke volume of a regurgitant valve minus stroke volume of competent valve. And remember that PISA can also be used in aortic regurgitation. And just few numbers to remember. Ejective regurgitant orifice area of 0.3 cm squared and regurgitant volume of 60 mL denotes severe aortic regurgitation. Vena contracta 6 mm also denotes severe aortic regurgitation. EF of 50% and systolic dimension of 5 cm is the threshold of LV decompensation. Remember, the pathophysiology is different from acute versus severe regurgitation. So the only proven intervention is aortic valve replacement. Remember not to operate too early, but at the same time also remember not to operate too late, okay, in patient with severe aortic regurgitation. So I thank you so much for your attention. So that is our talk for today. So I am very happy to listen to any question if anybody have question. So thanks for spending some